In many public health and clinical studies, we are not only interested in whether an event occurs, but also when it occurs. So, in this video, we'll be looking at survival analysis, specifically Kaplan-Meier curves, which are used to analyze time to event data in public health. Survival analysis focuses on the time it takes for a specific event to occur. This could be time until death, disease onset, recovery, or even hospital discharge. An important concept in survival analysis is censoring. Not every individual in a study experiences the event during the observation period. Some may be lost to follow up, withdraw from the study, or the study may end before the event occurs. These cases are called censored observations, and they are still important for the analysis. Now let's walk through how to go about this in R. In this analysis, we'll walk through how to perform survival analysis using Kaplan-Meier curves in R using a real-world lung cancer dataset. This type of analysis is widely used in public health to understand how long it takes for events like death, recovery, or relapse to occur. We begin by loading the required packages. In my case, I already have these installed, so I'm simply loading them into the session. The survival package provides the core functions for survival analysis, while a ggplot2 and survminer help us create clearer and more informative visualizations. I'm also suppressing warnings to keep the output clean for presentation purposes. Next, we load the dataset. This is a built-in dataset containing clinical data from lung cancer patients. To understand what we're working with, we inspect the structure of the data, look at the first few rows, and generate summary statistics. This step is important in any analysis as it helps us understand variable types, ranges, and any potential data quality issues. Now that we've loaded the dataset, let's take a closer look at what information we actually have. We can see that the dataset contains 228 observations, which means 228 patients and 10 variables. Each row represents an individual patient, which is typical in clinical and public health datasets. Looking at the variables, time is one of the most important for our analysis. It represents the survival time in days. This is our key outcome variable. Alongside that, we have status, which tells us whether the event occurred. In this dataset, a value of 2 means the patient died, and 1 means the observation is censored. We also have demographic and clinical variables like age and sex. Sex is coded numerically here, which will later convert into meaningful labels. Then we see performance-related variables like ECOG score and Karnofsky scores, which are commonly used in oncology to assess how well a patient is functioning. These are important in public health because they help explain differences in survival outcomes. We also have variables like meal calories and weight loss, which give insight into patients' nutritional status, another key factor in disease progression and recovery. Notably, we can already see some missing values in these variables, which is very common in real-world clinical data. Next, we look at the first few rows using the head function. This gives us a snapshot of individual patient records and helps us verify that the data looks reasonable. For example, checking that survival times and status values make sense. Finally, we examine the summary statistics. This gives us a quick overview of the distribution of each variable. Let's walk through the summary statistics of our dataset and unpack what we're seeing. We're looking at patient-level data, and each variable gives us a different lens on survival and health status. Starting with time, this represents survival time in days. We can see a wide range from as little as 5 days up to 1,022 days. The median survival is about 255 days, while the mean is higher at around 305 days. That difference suggests a right-skewed distribution. Some patients survive much longer than most, pulling the average up. Next is status, which tells us whether the patient was censored or died. The values range from 1 to 2, with a mean of 1.7 to 4. Since 2 typically indicates death in this dataset, it looks like the majority of patients experience the event, meaning death, rather than being censored. Looking at age, patients range from 39 to 82 years old with a median age of 63. The mean is very close, around 62.5, so age is fairly symmetrically distributed. For sex, the values are coded as 1 and 2. The mean is about 1.395, which suggests there are more individuals coded as 1 than 2. Typically, males are coded as 1 in this dataset, so the sample likely has more men than women. Now let's move to performance and health indicators. The ECOG performance score, pH.ECOG, ranges from 0 to 3, where higher values indicate worse functional status. The median is 1 and the mean is just under 1, suggesting most patients are still fairly functional but with some impairment. The Karnofsky performance scores, both physician-rated ph.Karno and patient-rated pat.Karno, range from about 30 to 100. Medians are around 80, indicating that most patients are able to carry out normal activity with some effort. These scores are slightly skewed toward better functioning. Looking at meal.cal, or daily calorie intake, there's a lot of variability, from as low as 96 to as high as 2,600 calories. The mean is around 929, but notably there are 47 missing values here, which is quite substantial and could affect analyses. Finally, weight loss, WT.loss, ranges from minus 24 to 68 pounds. The negative values suggest some patients actually gained weight. The median weight loss is 7 pounds and the mean is about 9.8, indicating that weight loss is common but varies widely. There are also 14 missing values in this variable. Overall, this dataset shows a patient population with moderate survival times, mostly male, generally in their 60s, with varying degrees of functional impairment and noticeable variability in nutrition and weight changes. Missing data is something to keep in mind, especially for calorie intake and weight loss, as it could influence downstream analysis. Moving on to data preparation, we first create a new variable called event. In survival analysis, we need a clear indicator of whether the event of interest, in this case death, has occurred. The dataset codes this as 1 for censored and 2 for death, so we recode it into a more standard format where 1 represents the event and 0 represents censoring. We also convert the sex variable into a factor, labeling the groups as male and female. This makes the data easier to interpret and allows us to compare survival outcomes between groups later on. Next, we create a new dataset called lung_clean. This is essentially a filtered version of the original dataset, where we're focusing only on a subset of variables and removing incomplete cases. First, we're selecting just 4 key variables: time, event, sex, and age. These are core variables typically used in survival analysis. Time represents survival duration. Event indicates whether the outcome occurred, and sex and age are basic demographic predictors. Then we apply an datamit. This function removes any rows that contain missing values in any of those selected columns. So if a patient is missing even one of these 4 variables, their entire row is excluded from this cleaned dataset. The result is a dataset with complete cases only, no missing data for the variables we care about. This is important because many statistical models, especially in survival analysis, require complete data and won't run properly if there are missing values. However, it's worth noting that this approach can reduce the sample size and potentially introduce bias if the missing data isn't random. So while it simplifies analysis, it's always a trade-off between data completeness and representativeness. Before jumping into survival analysis, we perform a brief exploratory data analysis. We start by visualizing the distribution of survival times using a histogram, which helps us see how long patients typically survive. So let's take a closer look at this histogram showing the distribution of survival time measured in days. Right away, we can see that the data is not symmetric. It's right skewed. Most of the observations are clustered on the left side of the plot, with a long tail stretching out to the right. That tells us that while many patients have shorter survival times, a smaller number survive much longer. The highest concentration of patients appears to fall roughly between about 100 and 300 days. This is where the bars are tallest, indicating the most common survival range. As we move further to the right, beyond 400 or 500 days, the frequency drops off quite noticeably. There are still patients surviving into the 600, 800, and even 1,000 day range, but these cases are relatively rare. This long right tail is important. It suggests the presence of a few long term survivors who are pulling the average survival time higher than the median. That aligns with what we typically expect in medical survival data. Another thing to note is the spread. Survival times vary quite a bit, from very short durations to well over 2 years. This variability highlights the heterogeneity in patient outcomes. Overall, this plot reinforces a key takeaway. Most patients experience shorter survival times, but there's a meaningful minority who live substantially longer, which is critical to account for in survival analysis. We also look at the number of events versus censored observations and the distribution of patients by sex. Starting with the event variable, we see two categories, 0 and 1. There are 63 observations where the event is 0 and 165 where the event is 1. In the context of survival analysis, this typically means that 165 patients experience the event, that is death, while 63 were censored, meaning they were still alive or lost to follow-up at the end of the study period. This tells us that the majority of observations are actual events rather than censored cases, which is useful because it gives us more information to estimate survival patterns with greater confidence. Next, looking at sex, we see 138 males and 90 females in the dataset. So the sample is somewhat male-dominated, with males making up a larger proportion of the study population. This imbalance is important to keep in mind, especially if we're planning to compare survival outcomes by sex. Differences we observe could partly reflect this uneven group size. Both tables give us a quick snapshot of our dataset. Most patients experience the event of interest, and there are more males than females included in the analysis. Finally, we use a box plot to compare survival times between males and females, giving us an initial sense of potential differences between groups. Starting with the median, which is the line inside each box, we can see that females appear to have a slightly higher median survival time than males. This suggests that, on average, females in this dataset tend to live longer after diagnosis. Looking at the spread of the data, the height of the boxes, which represents the interquartile range, both groups show a fair amount of variability. However, the female group appears to have a slightly wider spread, indicating more variation in survival times. The whiskers, which extend from the boxes, show the range of most of the data, excluding outliers. Both males and females have survival times that extend from quite low values up to several hundred days, but females again seem to reach slightly higher upper ranges. Overall, while there's considerable overlap between the two groups, the plot suggests a modest survival advantage for females compared to males. This kind of visual comparison is often a first step before running more formal analyses to determine whether the difference is statistically significant. Now we move into the core of the analysis, Kaplan-Meier estimation. We begin by creating a survival object using the serve function, which combines the survival time and event indicator into a format suitable for analysis. This object is fundamental to all survival models in R. We then fit a Kaplan-Meier model to estimate overall survival. This model calculates the probability of surviving beyond different time points, taking into account censored observations. We can also print a summary of the model to see survival probabilities at various times. Now we're looking at the summary output from a Kaplan-Meier survival model, where we are estimating overall survival across all patients. Each row in this table represents a time point where at least one event, typically death, occurred. Let's break down the key columns. The time column shows the number of days since the start of observation. At each of these time points, something changed in the survival curve. The n.risk column tells us how many patients were still at risk just before that time point, meaning they were still being followed and had not yet experienced the event. Next, n.event shows how many events occurred at that specific time. For example, early on at day 5, there's just one event. But at some time points, like day 11 or 163, we see multiple events happening together. The survival column is the key output. It gives us the estimated probability of surviving past that time. At the very beginning, survival is close to 1, meaning nearly everyone is still alive. As time goes on, this value steadily decreases. For instance, by around 200 to 300 days, survival has dropped to roughly 50 to 60%. That tells us that about half the patients have experienced the event by that point. This is closely related to the median survival time. As we move further out beyond 500 or 600 days, survival drops much more sharply, eventually falling below 20%. And by the end, around 800 to 900 days, it's down to under 10%. So long-term survival is relatively rare in this cohort. The standard error increases over time, which is expected. As fewer patients remain at risk, our estimates become less precise. Finally, the 95% confidence intervals widen as time goes on. Early in the study, the interval is very tight. Almost everyone is still alive, so we're very certain. But later, when only a small number of patients remain, there's much more uncertainty in the survival estimate. Overall, this table tells a clear story. Survival declines steadily over time with a significant drop in the first year and increasing uncertainty as the number of patients at risk decreases. This is exactly the kind of stepwise pattern we expect from a Kaplan-Meier survival analysis. Next, we visualize the Kaplan-Meier curve. This plot shows how survival probability decreases over time. Each step downward represents an event, such as a death, while censored observations are typically marked along the curve. This type of visualization is extremely useful in public health for understanding survival patterns in populations. Now we're looking at the Kaplan-Meier survival curve, which gives us a visual representation of how survival probability changes over time. On the x-axis, we have time in days, and on the y-axis, we have the probability of survival, ranging from 0 to 1. The solid stepwise line is the estimated survival function. It starts at 1, meaning that at time 0, all patients are alive. As time progresses, the curve drops in steps. Each drop corresponds to an event, typically a death, occurring at that time point. Early on, the curve declines gradually, indicating that events are happening but not extremely rapidly. As we move into the 200 to 400 day range, the drops become more noticeable, showing a steady accumulation of events. Around the midpoint, roughly where the curve crosses 0.5, we get an estimate of the median survival time. From the plot, this appears to be somewhere in the range of about 250 to 300 days, meaning that about half the patients have experienced the event by that time. As we continue further out beyond 500 or 600 days, the curve continues to decline, but more slowly in terms of steps because fewer patients remain at risk. The dashed lines above and below the main curve represent the 95% confidence intervals. Early in the timeline, these bands are quite narrow, indicating high confidence in the survival estimate. But as time goes on, the bands widen. This reflects increasing uncertainty since fewer patients are still being followed. By the time we reach 800 to 1,000 days, the survival probability is quite low, under 10%, indicating that only a small fraction of patients are long-term survivors. Clinically, this suggests that lung cancer in this cohort is associated with relatively poor prognosis, with most patients experiencing the event within the first year. However, the presence of a small group of longer-term survivors highlights that outcomes can vary. and factors like patient characteristics or treatment differences may play an important role in extending survival. Overall, this curve shows a steady decline in survival over time, with most of the drop occurring within the first year, and increasing uncertainty as the number of patients at risk decreases. Finally, we extend the analysis by comparing survival between groups, in this case males and females. We fit separate Kaplan-Meier curves for each group and visualize them using the SurvMiner package, which produces publication quality plots. This plot also includes confidence intervals, a risk table showing how many individuals remain at risk over time, and a p-value from the log rank test, which helps us determine whether the difference between groups is statistically significant. Here we're looking at a Kaplan-Meier survival analysis comparing overall survival between male and female patients. Starting with the axes, the x-axis represents time in days, extending out to approximately 1,000 days, and the y-axis shows survival probability, ranging from 0 to 1. There are two survival curves displayed here, males in orange and females in blue. Each downward step in the curves represents an event, typically death, while the small tick marks indicate censored observations, patients who were either lost to follow-up or still alive at their last recorded time point. One of the key visual takeaways is that the female survival curve consistently remains above the male curve across most of the follow-up period. This indicates that at nearly every time point, females have a higher probability of survival compared to males. The shaded regions around each curve represent 95% confidence intervals. These intervals widen over time, reflecting increased uncertainty as the number of patients still under observation decreases. The p-value shown on the plot is 0.0013, derived from a log rank test comparing the two groups. This is well below the conventional threshold of 0.05, indicating that the difference in survival between males and females is statistically significant. Below the main plot, the number at risk table shows how many patients remain under observation at key time points. At baseline, there are 138 males and 90 females. As time progresses, these numbers decline, and by 1,000 days, only 2 males and no females remain at risk. This reduction contributes to the increasing width of the confidence intervals later in the curve. From a clinical perspective, this analysis suggests that female patients have a survival advantage compared to male patients in this cohort. This difference is not only visually apparent, but also statistically significant. In practice, this could reflect underlying biological differences, variations in disease progression, response to treatment, or differences in comorbidities between sexes. While this result alone doesn't establish causation, it highlights sex as an important prognostic factor that may warrant further investigation and could be considered in risk stratification or personalized treatment planning. You are now familiar with how survival analysis can be applied to real clinical data to generate meaningful insights about population health and patient outcomes over time. In the next video, we will build on this foundation by introducing the Cox proportional hazards model, which allows us to examine how multiple variables influence survival over time. This is one of the most widely used methods in clinical and epidemiological research. Be sure to subscribe to the channel to continue learning more about data analysis in public health.